Dr. Kashi. He's in practice since 1980. He's a member IAP COI, past president IAP Bangalore.
Asthma, is a chronic inflammatory disorder of the lung. And here, Dr. Kashi, he will talk on the current concepts of asthma. And Dr. Kashi, please.
Thank you. Well, asthma is on the increase. We all know, we have experienced it in our practices. We have some hard data now. The ISAC study, which was done in 2007, examined the incidence of wheezing and asthma in 6 to 7 year olds, and a phenomenal figure of 6% of wheeze and 4.5% of asthma emerged in 6 to 7 year old children. Convert this into numbers, we have a tremendous load of asthma. And believe me, asthma is the most underdiagnosed and probably the most undertreated disease, chronic illnesses that are found in children. Let's start the story with young Mohit. He's an 8-year-old boy, brought to your clinic with cough off and on for 2 years, usually no fevers. He doesn't like to take part in sports, lot of school absenteeism. Father has some dust allergy. He has a pet dog at home. When you inquire further, you come across the information that the cough is recurrent, increases at nights and when he plays. Sometimes it's more, sometimes it's less, but over the past 1 month it has worsened. He has missed 5 school days. Even when he doesn't have significant cough, he coughs when he runs. And mother says that he usually keeps his mouth open and snores, specifically in the rainy season. On examination, he is averagely built, no clubbing. He has some evidence of atopic dermatitis, a few patches here and there. He has bilateral expiratory rhonchi. He has hypertrophic inferior turbinates on examination of the nares. So the next question, the mother has gone to quite a few doctors. Doctor, is it asthma? So how do you diagnose asthma? Diagnosis of asthma is basically clinical. A history of characteristic symptoms, cough, wheezing, shortness of breath. The cough is recurrent, non-productive, essentially non-productive. A productive cough, like this, straightaway downgrades the possibility of asthma. There's usually a nocturnal increase, and it's triggered by exercise, etc. The wheezing is also recurrent, nocturnal, and triggered, and the shortness of breath is also triggered by exertion or exposure to allergens. This, along with evidence of variable airflow limitation from bronchodilator, reversibly testing or other tests. So the last line is something that is something new in the diagnosis of asthma. So do we need investigations for asthma? We all know that asthma is basically a clinical diagnosis. Till recently, we always felt investigations are only for ruling out alternate diagnosis or for dealing with comorbid conditions. It was never recommended that spirometry is necessary for the diagnosis of asthma. But now in the 2017 and 18 guidelines, the first part holds true, but the present guidelines emphasizes a need for spirometry or PFR to document evidence for diagnosis, preferably before starting any controller therapy. So this is something new in the diagnosis of asthma. So once you take the history, do the physics examination and suggest that your child could be having asthma, the usual response, doctor, are you sure about your diagnosis? So how can you be sure about that diagnosis? So once you have a compatible history and a physical examination, you do a spirometry. In the spirometry, if you have a bronchodilator reversibility of more than 12%, or you have a FEV1 FVC ratio of greater than 0.9, you are sure that it is asthma and you can start on treatment. Spirometry is Greek and Latin to most of us pediatricians. So what do? We skip that step. So if there's a clinical urgency or a spirometry is not available or not affordable, not feasible, and if the history is compatible, you can start on therapy. But to the question, are you sure it is asthma? Your answer will be, it is probably asthma unless you do a spirometry. So Mohit has a spirometry done. He has a FEV1 of around 56%, FEV1 to FVC ratio of 0.76, which is much lower than 0.9. And he has a bronchodilator reversibility of 22%, which is very high, indicating an extremely labile airway. Please remember, all that wheezes is not asthma. There was a very nice paper outside on asthma mimics. Persistent moist cough with expectoration, feeding difficulties, failure to thrive, stridor, clubbing, localized physical findings or localized radiological findings are the red flags. Think of things other than asthma, even if the child comes with recurrent respiratory symptoms. If the onset is in the first 6 months, very, very strongly consider aspiration syndromes, airway abnormalities, or even congenital heart diseases. Every child diagnosed with asthma has to be looked into for comorbid conditions because that is going to affect asthma therapy. You look at the nose. Is there any evidence of allergic rhinosinusitis? This Mohit had highly hypertrophic inferior turbinates. What about reflux? Symptoms related to the GI tract. Obesity is strongly linked to asthma because leptin, the hormone which is increased in pregnancy, is highly pro-inflammatory and has been shown to produce asthma-like symptoms. And lastly, in adolescents, the presence of psychiatric problems, especially depression, is often associated with very poor asthma control. So these comorbid conditions have to be looked into at diagnosis, not when treatment fails. So treatment has to be started simultaneously. So once you diagnose him as asthma, the next step is you have to assess how severe, are there any other things which may influence the treatment or course of this illness. So asthma control, treatment issues, and comorbidities. Asthma control, you look at the symptom control and you look at risk factors for future exacerbations. Treatment factors and comorbidities. Treatment factors are in children who have already taken some sort of treatment that does not apply to Mohit, who has never been on inhaled therapy. Now, what is level of control? There are 3 levels of control: controlled, partly controlled, and uncontrolled. And there are 4 parameters. What are the daytime symptoms? What are the nocturnal symptoms? Any limitations of activities and how much use of short-acting bronchodilators, SABA usage. So if any of these are less frequent than twice a week, it's a well-controlled asthma. If any of these are present maybe once or twice a week, it is partly controlled. If all of these are present at any one time in a week, it's called a poorly controlled asthma. And this is the classification that we use now to decide what medications are to be started for the child. Remember, lung functions is not a part of initial assessment. It is essential for establishing diagnosis and for follow-up, but not for determining what drug you are going to use for asthma. Mohit comes under the category of uncontrolled asthma. Okay? Now let us look at risk factors. Now, what is the importance of risk factors? If risk factors are present, they increase the risk of exacerbations in the near future, even if the child is relatively well controlled and asymptomatic. The risk factors are all outlined over here. You have modifiable and non-modifiable risk factors. You have risk factors for fixed airflow obstruction, including lack of ICS usage, and you have risk factors for medications side effects. Now, if you look at Mohit, he has multiple risk factors. So when you write your final diagnosis for Mohit, It's going to be uncontrolled asthma, multiple risk factors for exacerbations, and a risk factor for fixed airflow obstruction, plus comorbidity in the form of allergic rhinitis. So this is the complete diagnosis of Mohit's asthma. The next question the mother asks, how severe is the asthma? We always used to measure asthma severity based on what happened for about 4 weeks before starting therapy, and the severity decided what treatment to give. We all remember mild persistent, moderate persistent, severe persistent, and intermittent asthma. But now the entire paradigm has changed. We now assess severity after starting treatment and not before starting treatment. And what does the new classification state? Mild asthma is very occasional treatment and no risk factors. Moderate asthma is low dose ICS LABA, double dose moderate asthma. If it requires very high intensity treatment, it is severe asthma. So today, the grading of asthma severity is based on the level of treatment necessary to achieve control and not the severity of symptoms before you started treatment. So in Mohit's case, we cannot say how severe the asthma is because we still haven't started treatment. Next question, doctor, does Mohit have to take inhalers? How many times? How long? I think this was dealt with in it today. Relievers and controllers. Controllers are inhaled and oral. There is also a third group, the highly modern drugs, which doesn't come under the ambit of pediatricians. So let's not talk about it. Which drugs are you going to start first? That again depends upon the symptomology. If he needs SABA less than twice a week, no waking due to asthma, no risk factors, no controller medications. If he has all the three mentioned above, plus risk factor, you still use ICS. This is the new recommendation in 2017-18. So, very low symptom score, but risk for exacerbation, use ICS. If he has symptoms between 2 times a week and 2 times a month, you still use low dose ICS. Even if he has symptoms more than twice a week, you use low dose ICS. So the scope for low dose ICS has now broadened. On the other hand, if he has troublesome symptoms almost every day, wakes up very frequently, in that case, you use a ICS LABA combination if more than 12 years, or you use a moderate dose ICS if is less than 12. Remember, though we use a lot of LABA in the pediatric age group, strictly speaking, LABA is not recommended for use below the age of 12 years. On the other hand, if the presentation is with an acute exacerbation, you straight away need to start with medium or high dose of inhaled corticosteroids. Now, Mohit falls in this particular category, so he requires moderate dose of inhaled corticosteroids. Let's not talk about the benefit of second line controller medications because second line is second choice always. Okay. Now, what about the dose of ICS? Remember, low dose budesonide, which is the commonest inhaler that we use, steroid, up to 200 is low dose, up to 400 is moderate dose, and more than 400 is high dose. For fluticasone, it is 200, 500, and above 500. Spacers have to be used for reasons which Dr. Subramania discussed in great details. I will not go into the details of that. We have a variety of spacers available, but please remember MDI and spacer is the best, and be familiar with one particular piece of equipment for all your patients rather than trying everything that new that comes in the market. Now, Mohit is prescribed 200 microgram budesonide twice a day with a spacer. So does your consultation end with the prescription? No, there are a lot more things you've got to do. Inhaler skill training, what is asthma, why he needs to take medications even when he's asymptomatic, How should he recognize worsening? What should he do when worsening occurs? When should he rush to the hospital? Modifiable risk factors should be modified. The pet dog in Mohit's case, some breathing exercises, and is called for a review. So the first consultation doesn't end with the prescription. You have to give him a lot of time to have a successful asthma treatment. There are various asthma control tests for all ages. You have asthma action plans which tell the patient what to do when. Normally, you should call for a review about 1 to 2 months later, or if there's an exacerbation, at least a week later. Generally, when you review what is the control. Depending upon that, you adjust the treatment and then you review the treatment. So it's a continuous cycle of assess, adjust, and review. At 1 month follow-up, inquiry reveals that Mohit still has some bronchospasm. He has some daytime cough, awakens due to cough at least once a week. Now, does he need a step-up therapy? He hasn't responded. Before you step up, dwell into the details. He occasionally misses the dose because he's in a hurry to go to school. He doesn't find the spacer, so he takes the steroid directly. He doesn't hold his breath properly. The pet dog still sleeps with him on the same bed, so risk factors have not been modified. So before any step up, correct wrong technique, check adherence, check exposures, comorbidities, and incorrect diagnosis. Normally, step up is basically you go to a higher level of treatment. Once you start a higher level of treatment, maintain it at least for 2 to 3 months before you say it is effective or ineffective. And before every change, check these other factors which I have just outlined. After correcting for inhaler usage, Mohit remains asymptomatic. At the 6-month follow-up, when everything is fine, Mohit's mother asked doctor with great expectation, can Mohit's treatment be stopped now? He's doing so well, he doesn't cough at all. So when do you step down? At least 3 months of symptom-free period with improvement of lung function. And this is where a repeat spirometry is necessary, provided there are no risk factors. To step down, choose a period when there are no viral infections. He's not going to go on a trip in a short period. And every step down should be a therapeutic trial. If you are using inhaled corticosteroids, reduce dose by 25 to 30% every 3 months. Your step down is going to take another 6 months. If you are using a combination, reduce the ICS first and the LABA later on. Otherwise, you are going to get exacerbations. If you are using low dose ICS, you can switch over from twice daily to once daily. You can even introduce LTRAs, Montelukast, during the step down phase. Generally, the older the child, you cannot stop therapy. Some dose of ICS has to be continued indefinitely. The next question the mother asks now, when you're planning stepping down, Doctor, will Mohit outgrow his asthma? A very difficult question, doctor. What are the predictors of persistence? More severe and frequent wheezing episodes during preschool age, onset during school age, the presence of atopic dermatitis, family history of asthma, elevated serum IgE, and early development of bronchial hyperresponsiveness. Now, if you see, Mohit has 3 factors. And if you look at the time frame, Mohit fits into this bracket of atopic asthma where we do not expect him to go into complete remission. I think some degree of transparency is necessary at this stage. So having dealt with Mohit, we deal a lot with very young kids below the age of 5 years with recurrent wheezing. Many of them are viral, and we always initially classified them as early viral wheezers and multi-trigger wheezers, which today is no longer considered relevant. You look at the probability of asthma. If the symptoms following a respiratory tract infection are mild, last less than 10 days, there's a very high chance that this is a typical viral wheeze and will not benefit much from inhaled corticosteroids. On the other hand, if the symptoms last for more than 10 days, there are symptoms in between episodes, there is a family history of atopy, the chances are greater that this is a typical asthma and the child will benefit from inhaled corticosteroids. So this is what is to be done now in the case of preschool Vs. No longer do we do a phenotypic classification now. Diagnosis, again, as I just mentioned, treatment is the same step-wise step treatment. The dosage also I've just mentioned. Now, can we prevent asthma? Well, in children, we do have a window of opportunity, but what is going to be useful, we are not very sure. Single allergen avoidance, like avoiding dust allergy in the mother, has not worked. So current recommendations are avoid exposure to tobacco smoke in pregnancy and early life, encourage vaginal delivery, encourage breastfeeding, where possible, avoid use of paracetamol and broad spectrum antibiotics in the first year of life. These are the only recommendations which are of proven value. With that, thank you. Basically, paracetamol skews your response to a Th2 response, which is basically a pro-inflammatory response. It's not just paracetamol, it's with all NSAIDs also. That's the reason why paracetamol is to be avoided. Yes. Strong link between maternal and child consumption of paracetamol and later on incidence of asthma. Robust evidence. That's the only proven intervention.
Before the next presentation, I would like to invite Dr. Sushma Bai Madam to present the Rajaram Memorial Award 2018 to Dr. Sweta Thapa, Best Paper by Postgraduate in Social Pediatrics. Dr. Sweta is a dependent student of MIMS Hospital, Calicut. Thank you, Dr. Sushma Bai Madam.